All right, so 2 o'clock has arrived, so I'm going to get going for this afternoon or morning, I guess, depending on where you are in the country. Today's webinar is focused on the Council of Ministers of Education Canada and the Public Health Agency of Canada's report, The Health and Social Dimensions of Adult Skills in Canada. So today we're going to be sharing with you some of the findings of that report and talk about some of the implications for public health and how we can consider skills in our work in the public health system. So as you can see on your screen, you may be listening to this via Adobe Connect, but you could also call into our teleconference line. The number is listed there. And if you are on the teleconference line, we've already gone ahead and muted everybody's line, but if you want to unmute for whatever reason at the end when we're asking questions, you can press #6. All right. And I just want to let you know that today's webinar, including what is going on in the chat box, is being recorded. And you can go ahead and use the chat box at any time to ask a question as they come to you or to share resources during the presentation that you think might be useful to the group. So I'll be looking to the chat box to pull a lot of questions for the later segment of the webinar when we are addressing questions. So I am Carrie Emmerich, and I'm your facilitator today. I am a knowledge translation specialist with the National Collaborating Center for Determinants of Health. So the NCCDH is one of 6 national collaborating centers for public health in Canada. All the NCCs aim to make public health programs and policies more effective by increasing awareness of new and existing knowledge, identifying and helping address public health priorities, collaborating with established public health networks, and identifying gaps in knowledge relevant to applied research. Of relevant applied research. So as you can see on the map, we here at the National Collaborating Center for Determinants of Health are located in Antigonish, Nova Scotia. So given that we are in Antigonish, we want to begin by acknowledging that we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Maliseet peoples first signed with the British Crown in 1725. The treaties did not deal with the surrender of lands and resources, but in fact recognized Mi'kmaq and Maliseet title and established the rules for what was to be an ongoing relationship between the nations. So we acknowledge this land not only in thanks to the Indigenous communities who have held relationship with this land for generations, but also in recognition of the historical and ongoing legacy of colonialism. And I also just want to note that I actually am based in St. John, New Brunswick myself, and New Brunswick is also part of Mi'kma'ki and also the traditional and unceded territory of the Maliseet people. So at our collaborating center, our focus is on social conditions that influence health and narrowing the gap between the least and most healthy. Our audience is Canadian public health organizations and practitioners, and our work is really to explain and share what is known to to help public health positively influence health for everyone through their work. And what the document you're seeing on your screen is the cover of our most recent environmental scan, which has just been released about building a culture of equity in Canadian public health. So I just want to take a little pause to see where you guys are all coming from. So where are you situated in Canada listening to us today? Looks like we have lots of people coming from Ontario and some from Quebec and BC, maybe one from Alberta and a handful from here in the Maritimes where we're actually located. And I just want to also acknowledge that today, for the first time, we are offering this webinar with a simultaneous translation in French. So I just want to extend a really warm welcome to our Francophone listeners. We hope the experience goes well today, but we'd love any feedback you have to give as this is our first time. So now, without further ado, I'm going to introduce our speakers for today. So from CMEC, we have Yitian Tao, who is an analyst, and he has a Master of Science in Biostatistics from U of T, and is interested in the association between skills proficiency and various social outcomes of adults in order to identify target populations for policy and programming. And joining him for his portion of the talk will be Andrea Long, who is a Senior Policy Analyst in the Social Determinants of Health with the Public Health Agency of Canada. Her current focus includes partnering with others inside and outside of the health sector to leverage action on the social determinants and articulating the importance of intersectoral approaches to building a healthy population. And I believe she's going to talk a little bit about intersectoral approaches in her talk. And then after Yitian and Andrea speak, we're going to be joined by Karen Serwanka, who's going to talk a little bit more about the implications for public health. And I'll tell you a bit more about Karen before she presents. So I'm going to pass it off now to Yitian and Andrea. Thanks.
All right, so good afternoon, everyone. This is Yitian from the CMEC Secretariat. So as Terry mentioned, I will be, myself and Andrea will be presenting about the key findings of the report. And at this point, I just want to acknowledge all the partnership and all the work that went into the report. And it's really a collective effort that this was really possible. So I'll just go through, so for the outline of our presentation, we'll just start out by discussing the motivation for this report, as well as a brief overview of PIAAC for those who are not very familiar with the assessment, as well as key findings from the report, and finally the implications as well. And I'll pass it on to Andrea, who will introduce the presentation.
Thanks, Yitian, and hello, everybody. Thanks for joining us today. It's great to have you on the call. So I just wanted to start out by providing a little bit of context about why we embarked on this process of looking at the importance of skills. So we know that, I think everyone around the various lines today knows that how we live and how we work has changed profoundly in the last few decades, and as a result, so have the skills we need to fully participate in our really strongly information and knowledge-based economies and societies. So it's important for governments and educators, for others like health professionals, provide services and supports to Canadians to have a clear picture of the extent to which people in Canada possess the kind of foundational skills that are required in the 21st century. And these foundational skills are needed not only to succeed in the workplace and in a range of other social and community settings, but they're also the starting point for developing other more complex skills that may be needed in specific work environments or for specific tasks outside of the workplace. And we also know that skills are important because people with lower skill proficiency are at much greater risk of economic disadvantage, including higher likelihood of unemployment. So assessing the levels of skills across populations helps to identify areas where acquiring or strengthening our skills could help to close gaps in outcomes for individuals or groups, and particularly those who are facing other disadvantages. So speaking specifically about the importance of skills for health and social well-being, as I just mentioned, we know that skills are important for the labor market outcomes people obtain, whether it's the likelihood of being employed or of earning higher wages. But it's also become increasingly clear in both Canadian and in international research that skills have value for more than just getting and keeping a job. A skilled population can contribute to fostering healthy, cohesive, and productive societies and democracies. And it's those positive health and social outcomes that are the focus of our conversation today. There are persistent differences in the health and social well-being of high-skilled versus low-skilled individuals, and we can actually see these differences across a range of different countries internationally and in diverse political, economic, social, and cultural contexts. So the figure on this slide here shows that individuals with lower proficiency in literacy are more likely to report poor health, are more likely to believe they have little impact on political processes, and they're less likely to participate in associative or volunteer activities. It's the case not only in Canada, which are the one set of bars in this graph, but also in the Organization for Economic Cooperation and Development countries more generally. So in fact, this graph shows that Canada actually has a stronger relationship between skills and health and social outcomes compared to the averages across the OECD, which suggests that it's even more important to look at the importance of skills outside the labor market in our particular national context. So in terms of, I just want to say a few brief comments about what we already know about skills, how skills are connected to health, health in particular. So I think to start off, it's important to recognize that literacy and education are social determinants of health, alongside other factors like income, employment, gender, culture. Determinants of health are recognized to shape a person's chances of achieving and maintaining good health over the life course. So we also know, though, that 60% of Canadian adults don't have the skills they need to effectively manage their health. This may be because skills are needed to facilitate navigation of complex health and social care systems. You need skills to be able to locate and understand treatment options or information on the drugs you're taking and the dosages. We need skills to develop and maintain effective self-care practices. And we also can use our skills to confidently advocate for the kind of care, supports, and services that we need. So when we have low skills, people are more vulnerable to experiencing poor health outcomes, like increased hospitalizations, adopting more risky health behaviors and practices, and not having sufficient knowledge about how to use health services or the markers and practices that you can pursue to achieve good physical health. Since there is a price tag associated with how we use our healthcare services, with chronic illness and with particularly preventable diseases, illness, and injury, poor health can actually increase the cost of publicly funded services. So in that way, the contribution of low skills to poor health can be understood as a collective priority that we share in Canada. I'm going to turn it back to Etienne now to talk a little bit about the PIAAC survey, which is the basis of the data that we're presenting today.
Thanks, Andrea. So for those who are not very familiar with PIAAC, so that is short for the Program for International Assessment of Adult Competencies, and it is an initiative of the Organization for Economic Cooperation and Development, or OECD, which assesses the cognitive and workplace skills to successfully participate in 21st century society as well as the global economy. And it is a survey that is administered in over 30 countries, and it collected information on the skills of adults aged 16 to 65 through a household survey. And so how that relates to public health, of course, that is because PIAAC is not just an assessment of skills. The survey itself also collects information on how skills are used at work in everyday life, including cognitive skills and as well as non-cognitive skills. And it also collects a lot of information on the context of different socio-demographic and socio-economic factors of the respondents, so that we can observe their health and social outcome in relation to the skills. And the outcomes that are associated with skill level include self-reported health, trust, volunteering, and political efficacy. And in terms of PIAAC in Canada, it was conducted in 2012. The data was collected from 2011 to 2012 by Statistics Canada on behalf of the Council of Ministers of Education Canada, as well as the federal partners, the Employment and Social Development Canada, ESDC, and other provincial and territorial partners. So over 27,000 Canadians completed the survey in either official language, which was actually considerably higher than any other participating country. So that allowed us not only results at the pan-Canadian level as a whole, but also for each province and territory. At the same time, they also allow Canada to specifically look at certain subpopulations, such as Indigenous peoples in Canada, recent immigrants, official language minority population, which were oversampled to provide detailed information for each of these groups. And so what exactly are the skills that are measured in PIAAC? So that includes literacy, numeracy, and problem solving in technology-rich environment. So as the name implies, literacy is the ability to understand, evaluate, use, and engage with written text to participate in society to achieve one's goals. And numeracy, which is related to mathematical skills, is the ability to access, use, interpret, and communicate mathematical information and ideas, and to engage and manage the math demands of a range of situations in everyday life. And problem solving in technology-rich environment, or PSTRE, is the ability to use digital technology information tools and networks in order to acquire and evaluate information, communicate with others, or to perform other practical tasks. And we'll be referring to this as problem solving for the rest of the presentation for short. So of course, these are all the skills that we need in all aspects of our daily lives, whether it is written communication, fundamental math, or the ability to use digital devices, all of which are important for participation in our modern economy and society, and for the development of higher order skills. So next slide, we have the health and social outcomes that are measured by PIAAC. So PIAAC, as I mentioned before, it collects data on 4 main health and social outcomes. The first one is self-reported health, which is the subjective measure of a person's general health. So that is not only the absence of disease, but also a subjective sense of physical, mental, and social well-being. The second of which is trust, which is the confidence in the reliability of a personal system. So because we know that trust promotes cooperation, facilitates business and personal transactions, and contributes to the feelings of safety, as well as collective action in the pursuit of shared objectives. And volunteering here is defined as any activity in which time is given to benefit another person, group, or cause. And it is considered an important indicator of social engagement and civic participation, which benefit both society and the individual. And lastly, political efficacy is the extent to which a person feels that they understand and it can affect government action. And back to you, Andrea.
Thanks. So using the data from our analyses of those 4 health and social outcomes that Etienne just described, CMEC and PIAAC partnered to produce the report we're discussing today on the health and social dimensions of adult skills in Canada, which was just released in February of this year. So before we just get into talking about the report results and its implications, I just wanted to make a couple of quick comments about the development process. And Etienne alluded to this already, but I did just want to also say that the report really benefited from the wisdom of an extensive network of partners from federal, provincial, and territorial government departments, from universities, from research and community organizations. And as often the case with those sort of partnership-based models, they do take a long time to navigate. Sometimes you need a little extra time to bring people together, but they also yield unique rewards and insights. And I think that the work that's culminated in this report is really reflective of the value of that kind of process. And secondly, I just also wanted to acknowledge that PIAAC as a survey is important because it enables a social determinants of health analysis of skills data because of the way it collects information, not just on skills levels or the things we might tend to think are linked to skills, like the labor market outcomes, but also on health and social factors. So it's for this reason that for the Public Health Agency of Canada, it was an important opportunity for us to work with an organization like CMEC to build the evidence base on social determinants of health. And again, I just wanted to note that, from a public health standpoint, it's important to look for those kind of partnership opportunities with other sectors that have those policy and program levers available to influence key health determinants. So to get into the report itself, the overarching objective was to assess how literacy, numeracy, and problem-solving skills contribute to the health and social well-being, both of individual Canadians and also to the well-being of Canadian society as a whole. So to achieve that, we specifically wanted to assess a couple of things. First, whether or not skills themselves influence health and social well-being. That is, whether skills are linked to well-being separately from the influence of education. There's a lot more data and research out there on the link between education itself and health and social well-being, but less around the role of skills and whether that effect is independent of the relationship between skills and education. So that was one of our aspirations in the report. The second is to look at whether improved skills can better support health and social outcomes for certain population groups in Canada, particularly immigrants to Canada, older Canadians, and Indigenous people. I did just want to point out as well that although we're not going to discuss it today, the report does briefly consider other elements of the PIAAC survey that are related to health and social well-being. There are some questions about the presence of long-standing illnesses or health conditions, some questions about people who are remaining outside the labor market for health or family-related reasons. And we also did some preliminary analysis of the health and social well-being of people employed in precarious jobs versus more, traditional stable employment. So if you're interested in those issues, you'll find the discussion in the report, and of course you're welcome to follow up with us if you'd like to explore that in more detail. So again, I'm going to turn it back to Etienne to go through quickly, because there's a lot in the report, but quickly some of the highlights on the results.
Yeah, thanks, Andrea. So today, as Andrea mentioned, this by no means cover all the key findings from the report, but we thought that we'd just highlight a few of them for you today. So, so firstly, as we already mentioned, Canadians in general do report strong health and social outcome. And in fact, they report some of the best outcomes among participating countries, including self-reported health, trust, volunteering activity, and political efficacy compared to other OECD countries. So as you see in this figure, Canadians generally report, the proportion of Canadians reporting excellent, very good, or good health is well above the OECD average. And again, that is true for the other outcomes as well. So if we go more detail into the other health and social outcomes, we see that, and how they relate to skill level, we see that Canadians with higher skills tend to enjoy better health, trust more people, participate more in volunteering activity, and are more likely to think they can influence government. So as you can see here, moving from level 1 or below to level 2 or level 3 and level 4 or 5, we see a gradual increase in the proportion of Canadians who report positive health and social outcomes. So again, we see that those with higher skill level tend to report positive outcome compared to those with lower skill levels. And of course, so although higher skilled Canadians consistently report better outcome than those with lower skills, it varies. That is only a general overview. Of course, it varies across other socioeconomic and socio-demographic characteristics. So the first one of which is age. So here we see that higher skill reduce the gap in self-reported health between younger and older Canadians. So as we can see here, for those who are aged 55 to 65, are generally less likely than Canadians in younger age group to report positive health and social outcomes, as you can see from the gray bars. But while the skills and health and social outcomes commonly decline with age, we notice that older Canadians that are at the higher levels are actually much more likely to enjoy positive outcomes. So as we can see here, for example, if you look at Canadians who are aged 55 to 65 at level 4 or 5, 92% of them report positive health, and that is actually on par with the other younger age groups at lower skill levels. So we see that skills is correlated with reducing the gap in health status. And next we turn to gender. So we see that as skills improve, both men and women tend to report better health and social outcomes, similar to what we see before. And in fact, there is little variation between outcomes reported by men and women. And this applies for self-reported health as well as other outcomes such as trust, volunteering, and political efficacy. Although we do see, if you look at the report in more detail, we do see that women tend to be more trusting, to volunteer more, and to feel that they have some influence on government than men. And if we turn to the next slide, which is education, again, same story. We see that Canadians who attain higher levels of literacy, numeracy, and problem-solving skills report similar high levels of self-reported health, and that is regardless of their educational attainment. So even among respondents with lower levels of education, higher skills are in fact correlated with better self-reported health. So an example here is that those at level 2 or 3 in problem solving, for those with less than a high school diploma, is at 92% reporting positive health. And that is actually higher, or slightly higher than those with a bachelor's degree or higher, but who scored at level 1, or who scored at below level 1. So you can see comparing the 92% to the 90%. So this implies that Canadians who attain higher scores in literacy, numeracy, problem solving tend to report higher levels of health outcome, and that is regardless of their level of education. So what this tells us is that skills themselves are closely tied to health and social outcomes. So they're not simply just another proxy for one's level of educational attainment, and they're really separate factors in whether or not people report good health or not. So this is also true for others in the labor market as well. For example, the unemployed Canadians, and this report indicates that employed Canadians are more likely than unemployed Canadians to report positive outcomes for health, as well as for the other indicator of social well-being. This is unsurprising since past research generally showed that unemployed individuals tend to report poorer mental and physical health, lower social support, lower levels of organizational membership, lower social and institutional trust, and are less likely to vote. What we do find surprising here is that the health and social outcomes of unemployed Canadians do not consistently improve as proficiency level rise, and that is unlike results for the other social demographic groups that we've seen so far. So in fact, we see that there's actually a slight drop-off for self-reported health for unemployed Canadians at the highest level for literacy. So we see for the unemployed, we go from 78 to 89, 92, and 84. So, of course, this suggests that skills, although information processing skills are associated with positive social and health outcomes, they are not the only factor, and they're not sufficient to mitigate all the disadvantages that are faced by unemployed Canadians. But, of course, that's another discussion for another day. Next, we were also able to look at the immigrant population. So we see that health and social outcomes vary between immigrant and the Canadian-born, as well as between Canadians who have been in Canada for less than 10 years, the recent immigrants, and those who have been in Canada for over 10 years. And so for overall, in three groups, again, we see that these outcomes improve, skills improve. But of course, it is important to keep in mind that health and social outcomes in immigrant Canada can be influenced by a variety of other factors other than skills, such as other cultural factors, their ability to, their official language capability, the length of residence in Canada, and at the same time, it's important to keep in mind that outcomes for immigrants are influenced by other socio-economic exclusions, which may impact how they report health and other outcomes. So again, is the point that while skills are important, we also need to look at other factors as well. Next, finally, we have the indigenous peoples in Canada. So in general, we see that the smaller proportion of indigenous peoples self-report positive health for health, trust, and political efficacy compared to the non-indigenous population. But likewise with other population groups, these outcomes tend to improve as proficiency level rises. Here we also see, for example, at level 1 or below, 69% of indigenous populations reported positive health, and that rises to 93% at level 4 or 5, which is essentially not any different from the non-indigenous population. And likewise, because of the historical context, it is critical to understand findings on these outcomes for indigenous people in the context of both historical and contemporary experiences confronted by indigenous populations in Canada, which of course include the ongoing legacy of colonization and the impact of social economic exclusion. And I'll just, at this moment, turn back to Andrea for some implications of these findings.
Thanks, Etienne. So, briefly then, we wanted to talk about what's important about all these findings. Why do we care about this data? So first, I hope it's pretty clear by now in our presentation that skills matter for health and social well-being. They're important resources to help people attain and maintain good health and to participate fully in its societies and its institutions. So despite the fact that skills matter, we know that high skills proficiency isn't a guarantee of achieving better outcomes, and that in some cases, compounding disadvantages are too much for higher skills levels to mitigate. So as Etienne mentioned, the groups we considered, this was most clear with respect to unemployed Canadians whose health and social outcomes don't improve as skill levels improve, unlike most of the other population groups we considered. So although it'd be interesting to investigate this in more detail to understand the relationships between skills and health and social well-being and unemployment, We think it might suggest that exclusion from opportunities to build social capital and networks in the workplace can further compound the instability that comes and the economic vulnerability that comes from unemployment and the lack of earned income there. But again, we'd like to be interested in pursuing more research to better understand that. So in terms of the report objective of looking at the independent effect of skills on health, the PIAAC data confirm that skills are indeed more than a corollary to education. They are important factors to affect outcomes in and of themselves. So the fact that Canadians with low levels of formal education, so even those who haven't completed high school, are more likely to report better health and social outcomes when their skill levels are high, suggests that skills could actually play a role in mitigating some of the negative outcomes that we know are often accompanying lower educational attainment. Things like increased mortality, increased use of healthcare services, and therefore associated costs, decreased earnings potential, and increased risks like housing and food insecurity. So this finding around education is also important from the standpoint of decisions about where to direct interventions, because these results suggest that efforts to support people to acquire and maintain skills are maybe of value whether or not they're accompanied by achieving formal educational credentials. So it isn't necessarily just about getting that credential. It could be just about strengthening people's skills more generally, including their foundational skills like literacy, numeracy, and problem solving. Conversely, the fact that higher educational attainment isn't as strongly associated with positive health and social outcomes if skill proficiency is low points to the importance of interventions to support adults to use and maintain their skills at work and in the rest of their lives as well. And that is the case even for adults who have obtained a high level of formal education, but whose skills may still be at risk of declining over time. So a further implication, we know that some groups of Canadians, we know that skills are distributed unevenly across the population, and that health and social outcomes vary as well. So with respect to our objective of looking at differences in outcomes across population groups, these data confirm again that some Canadians are less likely to enjoy positive health and social outcomes. So most notably in this report, we already talked about the unemployed. It also includes those with lower educational attainment. As Etienne noted, Indigenous peoples also tend to report poor health and lower levels of trust and political efficacy. But again, as he pointed out, that finding must be connected to the legacy of colonialism in Canada, as well as ongoing social and economic marginalization and discrimination. And I also just wanted to note there that if anyone's particularly interested in the skills of Indigenous populations in Canada, there is a specific report that's being written on that as part of the PIAAC series that's not out yet, but is forthcoming. So that will, although that won't go into the health and social dimensions, it will explore skill levels in more detail. And so finally, the other important implication is the finding that skills may actually help to close some gaps. So while some Canadians have worse outcomes, skills could actually play a role in helping to level the playing field between certain population groups, narrowing some of the problematic gaps in outcomes. So I think we've seen this most notably in what Etienne presented with respect to differences between younger and older Canadians and between Indigenous people and other Canadians, where we see gaps narrowing as skills improve. So as with the relationship between education and skills that I just mentioned, this is also an important finding from the standpoint of considering where we might have potential to intervene to address health inequalities. So just briefly, a few thoughts about the public health community in particular. I'm going to offer some quick thoughts, and then, as Terry mentioned at the beginning, we're fortunate to have Karen Serwaka from Manitoba Health also speak to this, and Karen was a member of our task team who guided the development of this report, so it'd be great to have her thoughts as well. So just to begin, I did make the point earlier about the importance of partnerships, and especially partnerships with people and organizations outside of the health sector in order to support action on determinants of health. So I just wanted to again underscore that, I think holding up the PIAAC report and the process of collaboration with the Council of Ministers of Education and with our range of other partners inside and outside of governments is a really good example of how we can work together with other sectors to build the evidence base to inform public health practice. So secondly, we all know that a key principle in practice is that it needs to be evidence informed. So I think we hope that the results we're presented today demonstrate that there is value in exploring the relevance of data perhaps from less traditional sources, even sources like PIAAC that aren't necessarily primarily about health. Knowing the skill levels of Canadians and the fact in particular that many lack the skills needed to cope with today's health or other information demands can help us to inform the design of our interventions or the material reused in health, social, or other settings. On a similar note, the health and social outcome data in PIAAC does suggest that there's value in thinking outside the box in terms of the types of interventions that have potential to improve health outcomes. So since we now know that more highly skilled Canadians also tend to be healthier and that gaps in health outcomes can narrow with rising skills proficiency, the data in PIAAC underscore that helping Canadians to attain and maintain good health can be about more than interventions that target personal health practices or that look at access to health services. The point there about the expansion of potential health content in PIAAC, I do think it's important to acknowledge, and some of you may be thinking this, we only talked about self-reported health as the outcome in PIAAC. The content at present still is fairly limited on the health standpoint in this survey, so certainly if there were ever an opportunity to strengthen that, it would permit further and more in-depth analysis. In particular, I think some things that would be of interest would be looking at health literacy specifically. There is no measure in PIAAC on health literacy, unlike some previous surveys. There's also no content about mental health, about how people use services, or about health promoting or risky behaviors, all of which could, I think, prove to have interesting links with skills. And then finally, I just did want to acknowledge, since we're talking about the landscape around public health, there is a lot of important work that's been done in Canada to support consideration of health literacy in clinical settings and other practice settings. I did include a couple of links here, and we can't use PIAAC to sort of enhance that health literacy analysis, but I just did want to note that, it is important to also think about the continued work in this area and the importance of that for the public health community and the health sector more generally. So just to wrap up, we've provided you with some links to the full report as well as to the executive summary. Those documents are available in English and French. There's also a link here to the PIAAC.ca website where if you're interested in either this report or any of the other reports or materials related to PIAAC data, that's where you can find them. And then we've also provided you with our contact information for me and for Etienne at CMAC in case you have any follow-up questions. And then I just, again, wanted to end with briefly acknowledging not only the collaboration between CMAC and FAC on this report, but the leadership provided by the Federal, Provincial, Territorial Advisory Committee for the entire PIAAC in Canada initiative, and including the thematic report series of which this particular report is a part. And I did want to thank the Health and Social Outcomes Report task team members as well, Karen being one of them. Their leadership, their insight and expertise was really invaluable in shaping the report and the data analysis behind it. So again, just wanted to acknowledge the importance of that partnership model and how it broadened our perspective on looking at the health and social dimensions of adult skills. And Terry, thank you for that. That's it for us. So I believe we're going to pass it over to Karen now.
Yep, so Karen is going to speak to you guys a bit about some considerations for public health coming out of this report and maybe how it can be integrated into practice. So as Andrea mentioned, Karen, I believe, is on the advisory group for this particular report, and she serves as a senior policy advisor for health equity with the Health Equity and Prevention Unit in the Active Living Population and Public Health branch of Manitoba Health Seniors and Active Living, and her aim is to carry out her work with a social justice approach. So, Karen, take it away.
Thanks very much, Terry. If anyone has trouble hearing me, just indicate and I will raise my voice. It's a great pleasure to join you here today and to follow on the great work that Yitian and Andrea have been leading. And I'd just like to begin by taking this moment to recognize that I am a settler living and working on Treaty 1 territory, the traditional lands of the Anishinaabe Nation and the homeland of the Métis Nation. And I acknowledge and pay respect to the original people whose lands upon which I live and work, as well as the other numbered territories across Manitoba, which include 2, 3, 4, 5, 6, and 10. And I'd also like to acknowledge the Cree, Oji-Cree, Dakota, and Dene nations, recognizing the uniqueness and contributions of each nation, and to acknowledge that in moving forward together on a path towards reconciliation, we still have a long way to go. So it is a pleasure to join you all virtually across the country today, and I'm hoping that this technology won't be too much of a test for my skills in a technology-rich environment. I've had the pleasure of also working behind the scenes with colleagues here in Manitoba from Education and Training Department, who are our province's departmental lead in anything PIAAC, including the advisory committee for the overall PIAAC work. And my contacts there have been Dallas Morrow and Regina Ramos-Urbano, who helped me get my head around what to focus on for this presentation, as well as colleagues within my own department, Jennifer Wood, who is hopefully on the line today. She does a lot of work related to healthy schools, and our director, Vicki Taves, and our executive director, Claire Betker. So today, I'm going to focus on, with literacy, numeracy, and the other adult skills being a social determinant of health, it's an area of interest and of program and policy responsibility of several sectors, of several government departments, as well as levels or jurisdictions of government. So these are key areas of consideration when public health examines or re-examines its role in addressing these skills and their impacts on the health and social outcomes that my colleagues have outlined already. So I'm going to attempt to touch at least briefly in this short presentation on the areas for public health to focus on. So on addressing literacy within our own sector and working within the broader healthcare sector, as well as our work with communities and on our work with other sectors. So as I explore with you the public health sector's use of this report going forward, it's helpful to perhaps frame it within the 6 essential functions of public health that are outlined on this slide. And I'm not sure how to bring up number 6, but it's health promotion here. So I won't review the definitions of each role in detail, but they're here for your reference, especially if you're accessing this presentation after the webinar today. So the 6 essential functions of public health being health protection, health surveillance, the assessment of population health, disease and injury prevention, disaster preparedness and response, and health promotion. So being a health promoter myself, I will probably overemphasize that, but I think health promotion theory and thought have influenced all other disciplines within public health. Oh, and there it goes. Sorry about that. I told you I was technologically challenged in this rich environment. Okay, so I would like to begin just on the whole issue of communications. So perhaps it's the most obvious area for action is in our communications with the public. So Here is an example from Manitoba, and it came on the heels of H1N1, in which plain language, along with predominantly visuals or pictograms, were used to communicate a very basic but fundamental message to contribute to stopping the spread of communicable disease such as influenza. So, although this may look quite straightforward, communicating using plain language principles requires knowledge and skills. It requires a concerted effort and time to consult, to engage, to plan, and even to test out our communications in the diverse communities in which we're working. So is it the message you intend to send? Is that the one being received? So in my opinion, there's a lot more room for this to become more intentional and with a greater emphasis on equity and on addressing root causes. Now, among the issues that I think we need to grapple with further, but I'm not going to expand on here, but just to flag it as an issue going forward, is that when considering levels of literacy in general and health literacy in particular, which PIAAC has yet to assess, the public health sector's communications with the public are really important. And in terms of navigating a huge volume of information on the web and discerning trusted sources from those that are less reliable, I think an issue for further consideration in the PIAAC surveys going forward and in our work in general in public health and other sectors is, should the importance of addressing literacy and the other adult skills be elevated? So that was just something that crossed my mind in this whole process of helping to develop this report. So the learnings from this report can be applied to a really broad range of work that the public health sector is engaged in or can engage in. So I've organized my thoughts around 4 categories, that being the work within the public health sector proper, which is this first column, work with communities that we work in, the second column from the left, the third column, broader healthcare system and our engagement in that, and our work across sectors, across departments, and across jurisdictions. So let's take a moment to look at these 4 realms or categories in more detail and the types of work that the public health sector can engage in. So within the public health sector, as Andrea has already mentioned, it's really important to share this new evidence base on social determinant of health, and that being the literacy and adult skills. And to seek and to engage in opportunities to do more knowledge exchange and translation with our colleagues. We can also apply it to population health assessment, and I'll give a couple of examples coming up from Manitoba. But we regularly engage with our regional health authorities in community health assessment, not only assessing the health status of the population, but looking at social determinants of health indicators, quality of health care, as well as access to health care. And so we have a lot of opportunities to integrate this and to apply the kinds of indicators and look at how to disaggregate it to get a better picture of population health assessment and health equity assessment as well. Within public health, where there are public health standards or public health standards are considered being developed, this is yet another social determinant of health to consider programming and reporting related to. And within communities, the same approach around population health assessment with an emphasis on community engagement. So if we're engaging with communities, what are the literacy, numeracy, and other adult skills considerations we need to even do outreach in the materials we share, in the input that we're seeking from people? These are really important considerations which sometimes are factored in more than others. And in all of the various kinds of health promotion initiatives that we engage in with communities, is literacy, numeracy, and the adult skills being factored in the planning and implementation of those. And again, in the broader healthcare system, we can begin to look at how do these learnings apply to the more specialized area of health literacy initiatives. Now, this is where I've been asked to concentrate. A lot of my efforts today is around cross-sectoral and jurisdictional, and Andrea has also already given a very good introduction to this. So I'm going to follow up on this in my upcoming slides. So I'd like to draw upon an example from Manitoba already where literacy has been identified as a social determinant of health, and that is in our most recent 2015 report from the Chief Provincial Public Health Officer on the health status of Manitobans. And in this one, there is an acknowledgement of literacy as an important component to help people gain access to the services that they need. And an example is given of how the cancer navigation hubs have began to address this as part of the cancer patient journey. Another example within Manitoba from outside of the health sector proper is from Manitoba Education and Training, the Healthy Child Manitoba office, which in their recent report, it was just released earlier this month on child and the Child and Youth report. The whole report is dedicated to the well-being of Manitoba's children and youth, and it recognizes literacy and numeracy amongst the cross-departmental priorities. And I've provided a quote from that recognition. So I'm going to go back to this slide because this is kind of at the crux of my presentation today. And although perhaps I'm not as advanced in my own presentation skills, what I'm trying to show is that the interventions that public health can and does engage in sometimes cross these areas. It's not distinct to that, but some of the interventions that we engage in where we can really integrate literacy, numeracy, and the other adult skills in a greater way are interrelated, and these shouldn't take place in silos. But the capacity building we could engage in going forward could help us to better understand and to better plan the type of initiatives and interventions that we embark upon. And as again, I have indicated that public health standards is one very formal way to do that. So I think one thing to keep in mind is who are our communities that we are working with. And in a slide coming up, I'm going to give you a link to a national forum that took place last week. And it was on the whole topic of literacy and health. And that was sponsored by Frontier College. And it was really a reckoning, I think, of how important literacy is to health outcomes. And the fact, one of the things that they were raising there, which I think is important to take into account, is that sometimes the first language people are trying to access health information or communicate in is something other than English or French. And that it's important that public health reckons with the diversified and sophisticated understanding of who our population is, so that Someone's first or subsequent language could be Spanish or Arabic, Mandarin, or Yoruba. So people may have strong literacy and numeracy skills in their first language, but literacy may be an additional consideration in English or French in which they're trying to access services. So within communities, community engagement, as I've mentioned, is key to the way we need to work and plan going forward. And within the broader healthcare system, we can apply the learnings from this report on health and social outcomes to our joint work together, if that's underway or it already hasn't happened, to explore what might a health literacy initiative or a formal strategy look like. And in our work cross-sectorally, how do we address adult skills to maximize the positive impacts on health and well-being and minimize or eliminate negative impacts, and how these are distributed in an equitable way. So we can factor in literacy, numeracy, and the other adult skills as a social determinant of health in any kind of impact assessment that we do here in the last column to the right on proposed interventions in other sectors. So I think literacy is important in and of itself in terms of accessing all kinds of information, including but not exclusively health information, in navigating systems, including the healthcare system, education systems, the justice system, in understanding what one's rights and responsibilities are, in being able to access educational, training, certification opportunities, and in employment opportunities which in turn impact on the income that a person is able to earn. So specific public health roles can involve identifying and assessing the population health and health equity impacts I've already referred to when planning a broad range of policies and interventions. And public health professionals can make recommendations for how to maximize those positive impacts and their equitable distribution, and for minimizing negative impacts and their inequitable distribution. So many of the sectors and their strategies are related in complex and even cyclical ways. So I've just tried to depict here that although we are talking about skills here, there is a relationship to other strategies and interventions that will be developed by other sectors, other government departments, and other levels of government. And the point is that we're working towards some kind of policy coherence, that we're rowing in the same direction and not working at cross purposes, and recognizing that there is legislation underlying a lot of these. So in addition to recognizing that there is the possibility for developing distinct health literacy strategies, for example, there are also things to consider in the healthcare sector around developing culturally appropriate healthcare and capacity within the health workforce to enable that. And so the ways that these things are related, for example, poverty impacts health. Health in turn impacts education. Education impacts health outcomes. And both of these impact employment, and employment itself impacts poverty. So the PIAAC results can help deepen our understanding of these complex relationships. So I just wanted to mention something that is current in Manitoba. In January of this year, our Manitoba Education and Training Department hosted a summit about learning for life and charting a future course for literacy and numeracy. And I've given you a website here at which you will be able to see when the strategy itself is released in the coming weeks. And so I encourage you to visit that and see where that strategy is leading towards. And they're asking me to wrap up here, so let me see if I've got these in order. So I think there are many things that public health sector can contribute to the ongoing dialogue on this and for future practical interventions. And two of those are related to thinking around more equitable outcomes and closing gaps on inequities, and thinking upstream in a prevention mode. And so these are two strengths and attributes that public health sector brings to this. So when we're planning at a population level, what groups are experiencing inequities in adult skills? And some of those are listed there, including people with lower educational attainment, often, but not always, people living in poverty, amongst Indigenous peoples, amongst newcomers, people involved in the criminal justice system, and perhaps some other sectors of society that we need to take into consideration. And how are we going to intentionally work to narrow those gaps and eventually eliminate them? Another attribute that public health brings is where would investment and action be most preventive? And if we're intervening early on in children and youth, we're talking about changing these inequities going forward. But that interventions and investment universally, intergenerationally, also have to be accompanied by investments to bring more equitable outcomes. And I would like to near wrap up by looking at some very interesting, innovative interventions which I haven't been part of, but I think deserve highlighting in two Manitoba public housing projects in Gilbert Park and Lord Selkirk Park here in Winnipeg. And they note in their recent Social Determinants of Health in Manitoba book that in order to build a quality living environment in public housing, social as well as capital investments are needed. And they talk about successful components of that. And amongst them, they list establishing community resource centers, having child care facilities, having literacy programs, and also adult learning facilities. So I just wanted to identify really, you know, how diverse our interventions need to be, and yet the importance of connecting these things one to the other, recognizing there's going to be no one magic bullet, but our ability to plan broadly and deeply and to connect up our efforts is vital. And I want to also note that for Manitoba, it's important for us to consider, and I think for anyone across the country, no matter what jurisdiction that you're involved in, is what does it mean to work in and with our communities? And we have a guiding document in our recently released strategy to transform the public service, and it emphasizes the importance of citizen involvement in shaping the services and interventions. And so I encourage you to look for guiding documents within your jurisdictions that can help to boost this work and to make some very important connections. Again, I'd like to make the emphasis, although the report doesn't touch specifically on health literacy, of the importance of health literacy being the ability to access, understand, and evaluate and communicate information as a way to promote and maintain and improve the health of our population and to address inequities. And that consideration for health literacy strategies that are that are related to these broader strategies is an important consideration going forward. And this is the link to that forum last week that I mentioned on health and literacy, and we will circulate to you another. This was actually the discussion paper, and there's a subsequent link that videotaped the proceedings of that national forum on health and literacy last week. Now, I would like to end where I began in terms of the key message that in terms of addressing inequities in literacy, numeracy, and other adult skills, it's really important to connect our work to reconciliation efforts. So I made the connection here to the Truth and Reconciliation Commission of Canada's call to action, which are, the categories are listed in the left column, and in the right column, for your future reference, I just identified some of the ones that specifically speak to skills. Skills both for people who may be on the low end of the skill spectrum, but skills for us all in terms of working towards reconciliation in our different professions. And so I've just identified for ourselves and for all of us here some considerations to take into account when we're working to close equity gaps in skills for Indigenous peoples by taking into account that there's considerable variation across the region, that literacy is often considered on its own, but the importance of numeracy shouldn't be lost, and that as with other population groups, health and social outcomes tend to improve for Indigenous Canadians as proficiencies arise. So these are areas where investments would make a difference. So with that, I will thank you, and it's been great, and look forward to hear what your questions are. Thank you very much.
Great, thanks so much, Karen. So I think the presenters today really made clear what a wonderful case literacy and skills are in terms of the truly intersectoral need for action when it comes to the determinants of health. So we've gone a little over in our presentation, but we still do have some time for some questions. We've had a few come through already, so I'm just going to kick it off with some of the questions that we've gotten in the chat box, and please feel free to add to the questions there if you have any. So the first question that we had was related to the PIAAC survey and why it is that adults over the age of 65 are not being included, given that retirement is no longer mandatory. So I think I'm going to pass that question off to you, Chen.
Right. Yeah, thanks, Kathy, for the question. That is a very good question. So I think for this cycle of PIAAC, because it was conducted in 2011-2012, so all the planning that went into the survey methods were done prior to that date. So that would have been done back in 2008. So that would have reflected the policy needs of its day. And also, as I mentioned in my presentation, it's important to remember that this is also an international assessment. So that is done in more than 30 different countries. So, and the age limit of 65 is what was decided upon by consensus at those meetings at the OECD from the countries. So that was what happened for last cycle, 2012. However, I should now mention that because PIAAC is actually a cyclical assessment, that's on a 10-year cycle. So the upcoming cycle of PIAAC will be done in 2021. And there have been discussions at the international level on oversampling respondents older than the age of 65. And at this point, it's nothing set in stone yet, but there's been preliminary discussions on increasing the age range, but most likely will not be something that will be done on an international level, but rather it will be countries will have the option to, if they need, to oversample respondents over the age of 65, so 66 to 75, if needed, if that answers your question.
Great, thanks, Etienne. We had another good question come in from Peggy Silvers, and she just noted that she recently watched a presentation by the Center on the Developing Child that identified self-regulation and executive skills as foundational to the development of literacy and numeracy, and that's where executive skills are the skills that you need to organize information and use that information in a flexible way once you achieve that information. So has there been any consideration in exploring or explaining these elements of adult skills and the potential for public health intervention? She says that this is some of the science presented to link literacy and poverty. So I don't know if Andrea or Etienne have anything to say about that or want to weigh in.
Oh, hi, so Etienne here. So from my perspective, what it seems is that it's the ability to adapt, to recognize different situations, to be flexible and adapt to them. That will, so again, for the next cycle of PIAAC, there's been talks on changing the problem solving in technology-rich environment component into what they call adaptive problem solving. So what they, so that is something that goes outside the scope of just literacy and numeracy. At this point, there haven't been specific questionnaires or items that were developed, but I'm not sure if that's what Peggy is referring to. So so the idea was the problem-solving technology environment in the last cycle. They thought that they had some problems with the component because they thought, the OECD thought that it tested more on the response and familiarity with technology rather than the problem-solving skills. So what they're trying to do for the next cycle is to be able to isolate that component of their skills that is independent of of any device that they may use. Hopefully that answers your question, Peggy.
Thank you, Jen. I think Peggy's just replying now in the chat box I can see. So we still have some additional time for more questions if anybody wants to write them in the chat box. In the meantime, I thought I would put a question forward. So in preparing for this webinar and trying to get some practice-based examples related to public health acting on literacy and adult skills as a determinant of health, we were struggling more than usual to find practice examples and people that could really speak to this. So I know this is just anecdotal, but I was wondering if any of you had some thoughts as to why maybe this particular determinant is one that's not necessarily being pursued as aggressively by public health.
Sorry, Terry, are you asking us, the presenters, to comment on that?
Yeah, I don't know if Andrea or Karen had any thoughts on that.
Well, it's Andrea, so I'll just say a couple things and then others can jump in. I think, I guess my initial reaction is I do think that there is attention to these issues in public health. I think it's primarily been framed through the health literacy lens as opposed to thinking about literacy and essential skills more broadly, which I don't think is problematic. I think it just kind of orients us a bit differently. So the health literacy question, I think, has primarily, I think, kept our focus within the health sector and the ability to use and process and health information. which is obviously important. But I think a broader sort of thinking more broadly about a determinants of health perspective, I think there's relevance in taking a more literacy and essential skills kind of approach to thinking about the issue, because skills are important to secure our well-being through the determinants of health as well, whether it's securing adequate employment, which leads us to sufficient income, whether we're able to feel included and have adequate social networks in our communities and in our workplaces. I think it's just a matter of a little bit of a shift in perspective on how we think about the skills work. Public health folks, I'm sure everyone is busy around the table, and it's hard to sometimes make those connections when we're all sort of focused on the things that need to be done immediately as well. So I think now that we can start to put some data in place to back up those connections, maybe we can start broadening out that conversation a little bit and thinking about how we might connect up our interests in health and well-being and mental health outcomes to the types of skills and training interventions that are being done in other sectors.
This is Karen. I think Andrea has answered that superbly. The other consideration, I think, is that when it comes to communicating with the public, I think the health sector in general and public health in specific do take due regard of literacy levels and such. The challenge is with the volume of information, with the complexity at times of the information being communicated, and how to convey that and capture that well enough. So that's that communicating with the public as the underlying interventions that I showed on my slides. But with any of the social determinants of health that we comment on and work with other sectors to plan interventions on, sometimes we grapple with what is our role in public health. And I think the emphasis on our ability to speak to what are the ways we can maximize positive and equitable health impacts and minimize negative ones shouldn't be underestimated. So there's the role for health impact assessment that could nicely work to emphasize more this and other social determinants of health in our work going forward.
Great. Thanks, Karen and Andrea. And we just have a comment back from Peggy again, and she's just saying that she agrees with Andrea, and she thinks that setting it in context that drives individuals to engage with the skills more than whether or not they can read the material is important. And she appreciated the examples that Karen gave related to truth and reconciliation. And she just noted that parenting skill development is one that she works with more often. So we had one more question that came through in the chat box, and I think this one is more for you, Chen, and it was just to ask, was there a particular reason that levels 4 and 5 had been collapsed together?
Yeah, thanks, Zoe, for your question. So there wasn't any theoretical reason why it was grouped together, just by the fact that at the OECD level and Canada as a whole, only 15% of people scored placed at level 4 or 5, and in fact only 1% of all population across the OECD and 1% in Canada can successfully perform tasks at level 5. So just in terms of sample size, for the purpose of analyses, it was grouped together.
Awesome. Thanks, Chen. I think we just have one more maybe comment coming back from Zoe. Oh, yeah, she's just saying thanks for the response. So since no other questions have come through, I'm just going to wrap up noting that at the NCCDH we have some upcoming webinars. In June we are going to present the findings of our environmental scan from last year and talk about the implications. And we also have a 4-part webinar series coming up on health promotion in Canada. So if you want to connect with us, you can see our contact information there on the screen as well. If you visit our website, we have lots of material available for you. You can connect with our network, Health Excellence Clicks. You can learn about workshops and events that we'll be hosting, check out our resource library, as well as participate in networking events and workshops. So before I finish up today, I just want to direct you to our evaluation survey. There's a link on your screen now, and we will also send out links in the future. We'd really love to hear from you and your experience with the webinar and what we can do to improve as we plan in the future. And if anybody on the French side who is listening to our interpreter has feedback to give, we would especially welcome that. So thank you so much to Yi-Tian, Andrea, and Karen. I think you brought some interesting reflections out of the report. It certainly got me thinking about a lot of things. In particular, what's sticking with me was Andrea's point about sort of just pivoting our focus a little to be more inclusive and not just focusing on health literacy, but other literacy skills as well in our practice. And I'm certainly going to take away that message with me. So thank you to all of you, and thanks to everybody who listened in today. And we will be posting this webinar, I believe, later on a video of it on our YouTube. Thanks.
Thank you.
Yeah, thank you.